Viet, good morning. And this goes for all of our APAC constituents, and really anybody else who's interested in watching this in the future. Um, that we're going. This is going to be a recurring monthly podcast. Maybe in the future we'll be able to organize this well enough that we can do it live. But for now, people can watch it after the fact. But we're really going to be highlighting, and this is just for the general audience. We're going to be highlighting different facets of cardiovascular medicine. To really see what not just what the officers and board members of APAC do, but just what a general cardiology APP does, and may not do, but needs to be aware of nonetheless. I mean, I think I have a pretty, as do you, have a very strong belief in cardiology does not stop at the heart. It's truly cardiovascular medicine. And I think that's what we're really going to try and hit home with. But today's topic of discussion is lipids, your favorite and my favorite. So might as well start out with a bang. Specifically, I know we're going to kind of talk about some of those high-risk groups that don't get enough attention, and specifically how that relates to guidelines, but more importantly talking about FH and FH testing and underutilization there. So I guess I'm going to put you on the hot seat to start with. What is your in your practice? I mean, what do you see at a you practice at an academic center. I'm at a large community hospital that kind of masquerades as an academic center. It's very much in its infancy in terms of academics and research. What's your typical lipid clinic look like? Your typical lipid patient that you're seeing that's being referred to you? I mean, are you seeing a lot of primary prevention? Are you seeing a lot of secondary prevention? Obviously, you have keen interest in FH.
Yeah, no, these are good questions. First, less people think that it truly is an academic center. I'm at Intermountain Healthcare, and we are a nonprofit healthcare system. Recently, of course, we took on SCL and are merging. I guess that's complete actually, and we've taken on Salzer and Nevada Health Partners. But the academic side is an interesting mix. We're a hybrid as well. We have affiliations with the University of Utah, with Stanford, but have created an internal academic ranking system. So I am an associate professor of research within Intermountain. Has a same kind of committee. We look at rankings and what publications are, what our contributions to our community and education, etc. But with regards to our advanced lipid and cardiovascular prevention clinic, we, I don't want folks to think that it's just lipids, but preventive cardiology includes
Right.
the whole and all of that. It mainly is secondary prevention. The primary prevention side of things, I will say, includes familial hypercholesterolemia, which in my mind is more of a risk equivalent than diabetes ever was. Here are the individuals that are having events well before 50, well before 60. It's arguably a coronary risk equivalent, as if you've had coronary disease. But the mix that we have really is still word of mouth. Dr. Jeffrey Anderson, my partner, and myself, we developed the clinic back in June of 2019. I was coming back actually, I was presenting at the National Lipid Association conference in Portland earlier that year in February on eicosapentaenoic acid. So EPA,
Yep.
reduce it had just been reported out in 2018. And so I was at a symposium and stopped by a colleague from my community who happened to meet me in Portland, a pediatric cardiologist who said, "Hey, where where is a lipid clinic at Intermountain Healthcare? Because I have pediatric patients who have FH. Their parents don't want to come to a pediatric hospital. And so that started the process of developing our advanced lipid and cardiovascular prevention clinic. It was based on making sure that we had a place for these adult familial hypercholesterolemia patients. But I am a researcher. I'm a clinical researcher, and I'm part of sponsored trials as well as investigator-initiated trials. One of our investigator-initiated trials is Target D. Yeah, vitamin D. And we can definitely talk about that in a later section. There's much to talk about in vitamin D.
We will have a cardiometabolic section podcast, so stay tuned.
Okay, good, good. So, in this case, what we're really asking in Target D is whether or not supplementing vitamin D in an acute coronary syndrome setting. So these are individuals with NSTEMI or STEMI. So they've had a troponin bump and an angiogram. Whether they're treated medically or not, there's some type of coronary event that's been identified and is being treated. Well, in looking for these patients, the inclusion, exclusion, I've already given you the inclusion, exclusion aside, this is a population where I recognize that Intermountain Medical Center, I was reviewing a lot of young MIs. So we think of premature for males, less than 55, less than 60 for females, but these are individuals in their early 40s and mid 40s. And I thought, wait a second, you should not be having MIs this early. Of course, very severe metabolic states, type 1, type 2 diabetes, renal disease, etc., can drive atherosclerosis. But outside of that, I was noticing LDL cholesterols that were definitely meeting the clinical criteria for familial hypercholesterolemia. So that's one way in which we enrich my clinic. I have a lot of networking with our general cardiology, interventional cardiology groups. And so I would reach out to the teams and say, hey, we have this clinic, and this comes back to your question of whether or not we should do genetic testing or not. And so hopefully we'll talk about that. But I told the teams, I don't want to interrupt what you're doing in terms of lipid management, in terms of secondary risk reduction. Perhaps we'll have some ideas for you. But I do think that these individuals need to be assessed for familial hypercholesterolemia, not for themselves per se, but what we can do for their families if we find a mutation. And then we'll talk about cascade screening. But that's one large part of how I bring patients into our lipid clinic. The other side is now word of mouth. They've seen enough of my electronic health record messaging that folks recognize we exist. And so they give us the quote unquote hard cases, right? The statin intolerant and high triglycerides, some of these other dyslipidemias.
Do you find, I mean, in your area, are you having, is it one large cardiology group that you're dealing with?
Yeah, no, this
or
is
multiple groups.
Yeah. I've worked in a system with multiple different competing cardiology groups in one hospital, and that's I don't think that's optimal. So I'm gonna give a hot take here, which is partly because I am biased as part of Intermountain, but I existed in a private cardiology clinic at one point as well, and that's where I blend my experiences. Currently, at Intermountain Medical Center, we are all Intermountain cardiology. And so from that perspective, it standardizes at least the care that's received in the process of communication. My former work about 15 years ago had about 4 different competing cardiology groups within a heart center. And it was very difficult. The nursing staff was consistently confused as to who was writing orders, who was managing which patient, etc.
That's the world I exist in.
Yeah.
And, not to get off too much on a tangent of hospital logistics or practice logistics. You know, I've had to fight that battle with trying to, you know, drum up as a private practice cardiology APP to put my shingle outside and say, hey, I practice, you know, I have a lipid clinic. To not say, well, hey, are you going to take my patient? You know, or you know, it's like, no, I'm not going to encroach on what you're doing. But, you know, if you're not going to do some of these more advanced things with lipid management, and like you said, look at families and try and do, you know, take that secondary prevention patient and flip it to a primary prevention for a relative. You know, yeah, and that's been a several year long process for me. So yes, it is confusing. It is not optimal, but it is it's the world I live in.
Yeah.
What do you feel like today? You know, here we are in 2022. Pretty soon it's going to be 2023. It sounds weird. Cardiology is so neat. I mean, we have interventional and structural colleagues, EP colleagues that can do amazing things.
Yes.
You know, there's devices, there's cryoablation, there's radio frequency, there's this stent, that stent. We're doing so much with, you know, reducing dual antiplatelet time with, you know, stenting and, you know, carotid stenting and whatever else there is under the sun. You know, preventative cardiology has been kind of the bastard child, if you will, for a long time.
Sure.
And I remind my students a lot that, you know, before all of this, before echo, before cath, lipids and hypertension, that was cardiology. This was it.
Yep.
So it's been fun to kind of see a resurgence, not only in technology going into lipids, but what we're seeing with, you know, MRAs and SGLT2s and now GLP1s. You know, if you and I talked about this, if you would have told me, you know, 5 years ago, almost 6 years ago, when I started practice, that I'd be writing GLP1s and SGLT2s, I would have laughed at you.
Yeah.
I said, no, I don't manage diabetes, but we've come a long way.
Right.
What do you feel like is the biggest pitfall for cardiovascular cardiology APPs right now with lipid management? For me, it is, you know, not to put our primary care colleagues, you know, on blast or anything like that, but it is the false assumption that they're going to take care of it, or the endocrinologist is going to take care of it. But I'd like to get your take.
No, I think the hardest part about all of this is we war against two different thoughts, and you kind of brought it up with regards to multiple cardiology groups vying for patients, and the common phrase of, are you taking my patient? So first of all, with a comment like that, I would say then take the patient and work with that patient. So you must be comprehensive if you're going to say that's my patient. And that means taking on the preventive cardiology role, not just doing your niche EP interventional structural heart thing. You must take on the comprehensive part of that patient. Otherwise, we need to put the patient truly in the pilot seat, and you're just helping navigate. And you have to realize that there are other navigators out there that have knowledge as well. And, you know, they have data 1.0, 2.5, whatever, in whatever space. So first, I'm going to lambast us as specialists that it's not your patient. That's a person. And we should be giving them as much knowledge as possible in our space to help them navigate, because ultimately they're in the pilot seat. So that's number one. Number two is that you can't punt. You can't punt. We work with primary care. We work with our EP, structural heart, our pulmonology, endocrinology partners to collaborate on care. And so if you are seeing the patient and you notice, you just said SGLT2 and GLP-1s, 5 years ago, oh, no, I don't treat that. Well, you have to be comprehensive to a certain extent, and you have to be okay with primordial prevention, and getting at optimizing a patient, whoever is having that touch point with that patient. We have to be able to inform and educate. So for me, the pitfall is just saying I'm staying in my lane, because my lane is actually healthcare, not just whatever happens to be my specialty du jour at that moment. So as a preventive cardiology and a clinical researcher, when I see a patient, I see all patients as consultative, even those that I consider my patients that are actually follow-ups over years. I still write an assessment and plan that includes references from papers, from studies, and I explain what I am doing when I put in a plan. If I say I'm considering SGLT2 inhibitors because of such and such, or because of this guideline, and that helps anyone that is anywhere near that note to understand what my thought process is, and that if I'm not starting that, they certainly should consider it. So often I CC my notes or add in Cerner, I can add people on to review. So I'll add primary care providers. I know they're not going to be able to read it when they're double and triple booked, but ultimately, if they do happen to get to it, then they'll see what happened when that patient that we share and that we're helping navigate has seen me, and there's some thought process that went into it. Same with endocrinology, if they're seeing a diabetologist, or the heart failure specialist, that I'm also watching for GDMT and those four pillars.
Right.
And I'll explain from my perspective as a preventive cardiology specialist what I think of when we are considering MRA, and defining that line between, well, if you're going to throw spironolactone, maybe you should think of finerenone or finerenone instead. Or, in this case, if you want to just throw in an SGLT2, let's talk about doses. And by the way, add a GLP-1 because there's some dyslipid, things going on. So that way it becomes a much more comprehensive conversation through the notes. I'm not a fan, and I'll just put it out there, I'm not a fan of the Epic or Cerner click boxes where we're using it as a billing platform. I still use my Cerner. I get rid of almost all of the templates and have created my own. And you know what it looks like? A soap note, because that's the narrative. I put in a narrative that's consistent with what I think is going on with the patient. I include notes and quotes from the patient visit. And then it falls into a reading, I think, an easily readable format. This disjointed thing where you put images over here and labs over here makes no sense, and it doesn't help someone to really find a flow and a narrative of what happened in any patient contact or visit. So those are the things. I mean, first of all, is no one owns the patient. The patient owns themselves, and we should be collaborating and helping them navigate the system as best as possible from our viewpoints, giving our, it's expert consensus opinion, really. And ultimately the patient is the one that has to make the final choice of whether they can afford something or whether it fits their values and goals. So those are the main points I would like to make. You opened up kind of an area that
I struck a nerve.
yeah, no, absolutely. You totally struck that nerve, and I just want to make sure that we are giving health care and not disease care.
Right.
That's the problem.
I concur. Shifting gears just a little bit, I tell my students all the time, lipids are fun.
Yes.
You're not, well, like we talked about yesterday on the phone, kind of prepping for this, is you're not going to hurt anybody.
Right.
Like the only thing you're going to do is help. The only way you can hurt them is just by kicking the can down the road, which everybody else is doing.
Yes.
So, you know, you don't want to follow the crowd, so to speak. How at your institution, it sounds like you've got, like you said, a lot of secondary prevention, a lot of post MI.
Yeah.
Mixed in with some statin intolerant, or how do you get people to really pay attention that are seeing some of your colleagues that might have had a stent 10 years ago, might have had a revascularization, might have had cerebrovascular accident, or, you know, carotid endarterectomy at some point, or not even, or hasn't had an event, just has carotid stenosis, if you will, or non-obstructive disease.
Yes.
Who's on high intensity, who's on maybe ezetimibe, but you know, their LDL is 80. They're not to goal.
Right.
I mean, that's my Achilles heel, is to get people as excited about that. You know, my colleagues are really good at sending the folks down the hall with 140, 150, 180 post MI saying help, 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 help.
Right.
But it's the, oh, you're okay. You know, 80 is not a big deal. You know, 72 is not a big deal. And what we know about LDL-C is driving that number down as far as we can go is a good thing.
Yes.
How do you get your colleagues, and what advice would you give to, you know, some of those that are going to, you know, tune into this podcast, who are saying, how do I get my colleagues to get as excited about lipids as I am in that patient population who so many think are either to goal or okay?
Yeah. Yeah, no, this is great. I think it's multifactorial and it'll take time. First of all, my working paradigm is that we all do this, by the way, it's human behavior. We treat to the last guidelines we launched into our careers from. And what I mean by that is I graduated in 2004. That was NCEP ATP3, JNC7. And it's taken a lot to overcome my own scientific inertia, being a clinical researcher and actually being involved in clinical trials, that has allowed me to overcome those basic tenets, those axioms that I thought were axioms at the time that I launched into my professional career. And it's held true each time as I've met folks who are coming out, you know, whether they're residents or they're PA students that are coming into practice. They speak about the recent guidelines, but if I mention anything older, they're like, what? However, the older, I won't say older because I am in that older category too, but those that came out much earlier, you mention newer guidelines and they say, what? So for me, it's about making sure that we understand the human behavior portion of this and where folks came out into practice, because you have to level them up from that, and you have to overcome the behavior that we all have, which is that last point where we were really studying and getting into boards and getting ready to go into practice. Those types of guidelines at the time or surrounding that time really get cemented into us. So how do we level folks up? Well, gently, and with this ALCAP clinic, the Advanced Lipid and Cardiovascular Prevention Clinic, what I have been able to do is slowly get into the consciousness and subconsciousness of my colleagues. It's been 3 years now, and through each patient contact that I have, that when my partners are willing to send me them, like I said, my assessment and plan is a mini CME. It's a mini in-service because I send them back. It's a consultative practice. I let them know what I'm thinking, how I went about it, and I give them the references within the patient chart. I give them the links so that if they want to just copy and paste that into a web browser, they can. If they want to use the latest ASCVD Risk Estimator Plus, it's in there. I actually put in the references to journals that I'm teaching their patients with. That includes, I love Erin Mikos's paper in the New England Journal of Medicine. I use her figure 1 all the time, and I make sure that they know what I'm teaching their patients. So each of them, which kind of is a little bit bad. The referrals were a lot in the beginning, but as my partners have learned, the referrals are less, and they're now more complex because those earlier kind of statin intolerant or, hey, what do I do with this? Well, now they know what to do with that because, instead of giving them a fish, you teach them to fish. So there's that part of it. The other is, how do you get people excited? Well, you are excited. So I give grand round talks. I go ahead and I leverage our group me. We have a group me where we have all of our cardiovascular advanced practice providers, and I will share tweets that are just mini bites or tutorials and say, hey, if you want to go through the entire thing, but the old TLDR, right? The short summary is this. And so I give them the quick update, and it's in their minds, it's in their consciousness, and I'm not overpowering them, but I'm giving them tidbits and parts that are fun that I'm like, hey, this is cool. Look, there's FACC AMI, which was just presented in April this year at ACC. If you get below an LDL cholesterol of 40, look what happens. You can regress plaque. And it gets into their mind that, yeah, okay, lower is better. Then I'm not like fighting over this, well, 72, or don't you know? I'm never confrontational, but I give them those little tidbits like, gosh, hey, high intensity statin first, think of ezetimibe or ezetimibe. And then there's this awesome thing called PCSK9 interfering drug. And I call it interfering because now we have monoclonals and siRNA. But I want them to get used to these little, tidbits. And that's what I think is the way to do it, is first teach through that communication process of a note. Make sure that the patient, if they ever get their notes, because they will get their notes, that they know what you were thinking and that it mirrors what you talk to them in clinic about. And then make sure that you're out there visible, that you are the lipid guru to folks. You are giving grand rounds, or you're giving, in-services or short presentations in your huddles. Make sure that you ask if you can be invited for a quick 5-10 minute update and quick tips and, takeaways. I think that that's helpful. But to blast and to alert folks without giving them a actionable takeaway, I think is tough because folks are like, look, I'm getting beaten down here. Don't just tell me one more thing that I should be aware of. Well, aware, and this is what you can do quickly. So I think those are the ways that we can really level each other up. Is you and I, we're experts here. So don't make them dig deep and into the weeds with us, but pull out those quick takeaways.
The a lot of I think of primary and secondary prevention a little bit differently than what the textbook definition gives us.
Sure.
Because I truly have more patients on PCSK9. We're shifting gears just a little bit on more of these advanced therapies, if you will, that are truly primary preventative. Now I live in the Southeast where we grow them not just big, we grow them bigger.
Yeah.
So, it's funny because, with finerenone and chronic kidney disease and diabetes, it's funny because they said, well, where should we really concentrate this drug? I said, outside my doorstep. Welcome to ground zero. Right. And the same is to be said for all facets of cardiovascular disease. My cardiovascular disease patient is a little bit different than what's walking into your office, just from socio-demographic and socioeconomic factors. So I do see a lot of patients that I kind of rework how I think of primary and secondary prevention. And people may think I'm a little bit crazy, but, truly secondary, okay, you have to have an event, MI, CVA, or some sort of limb event. But I think of it a little bit differently. I feel like if a patient had angina, they go to the hospital, they get a cath, and it's non-obstructive. That to them, that's an event.
Yeah.
They have placed themselves in a secondary prevention category, but we actually don't look at them as such. So
Right.
I think there's a little bit, of a disconnect there, but nonetheless, I have a lot of primary patients. I get a lot of statin intolerant. I get a lot of, maximally tolerated statin, or a lot of, very advantageous primary care providers who are trying to do the right thing and put them on PCSK9, but they've hit the roadblock and they've hit it hard, and they don't have the time or the energy or the expertise to be able to circumvent some of those roadblocks. What is something you see among your primary prevention patients? Any kind of trends or kind of pitfalls that we're making among those folks? I mean, I've always criticized my industry colleagues with Amgen, and also the folks at Sanofi with Praluent, because they've always toted that the post-MI patient is their poster child.
Yeah.
And I tell them that is absolutely 100% wrong.
Right.
Because you have failed that patient.
Yes, it's too late. It's too late.
It's too late. You failed. Somebody has failed that patient before they got on that cath lab table, and now you're seeing them after the fact. And I think a lot of that is starting to shift gears, and people are saying, oh, wow, okay, maybe that's not the ideal patient. Maybe we need to be preventing this stuff, not worrying about the second heart attack. So, I mean, I've been shouting from the rooftops for that. What do you see are some big challenges with the primary prevention crowd?
Yeah, no, and thank you for highlighting those things, because I often share, and I've done this since coming back to cardiology, is the analogy of or the story rather, of the fence or the ambulance, right? Do we wait until people go off the cliff and pick them up by ambulance, which may be too late and you're salvaging, or do you put the fence up and say, please don't go over the cliff? Warning, it stops right here. So I like putting up the fence rather than trying to salvage. And of course, there are people who will have events regardless. Those are, the more difficult, but many more can be kept on the other side of the fence. So the pitfalls, I think, are that we're still, the biggest problem that we're still in is fee for service. We're stuck in a fee for service. So procedures drive, well, what keeps the lights on in the hospital. It pays us. So we're a little bit more attuned to the patients that drive money. It's very difficult to propose a preventive cardiology clinic because we're keeping people out of the hospital. We're keeping people out of the cath lab, out of the emergency department, and we're keeping them from their second, third, fourth events. So the structure has to change by how we're paid and how healthcare is delivered, or how healthcare is paid for, because it'll incentivize the right things, which is what you're looking for. Is let's go before the event. I like to use a GIF from Minority Report, because the old Tom Cruise movie where you're trying to find the killer well before the murder happens. And that's what you're talking about. How do we incentivize and get people to think primordial, that in that primary prevention world, that's the more important area. It is true that a majority of people will probably have some other event or some other thing happen. We, 1 in 3 men, 1 in 3 women, but that still says that 60% plus or 2/3 will have some other type of event. So, how do we find those individuals? Who are the most risky? We use risk factors. We use ASCVD risk scores. I like to use coronary calcium. I think that the data is pretty dang good when we talk about non-obstructive coronary disease. Well, even then it can be argued when you find coronary calcium, it's they've already developed it. But what you're trying to do is prevent the event from atherosclerosis. So the end of
Correct.
it being stroke, MI, limb event, etc. And so I like the idea of utilizing coronary calcium in the right populations, just like you wouldn't do, a colonoscope on a pediatric patient for screening for, later cancers. You just wouldn't do a coronary calcium in a 20-year-old. However, I changed my mind when it's a familial hypercholesterolemic patient who I know has a 50% chance of having an event untreated if they're male and, 30% chance if they're untreated as a female. So I use coronary calciums earlier in those individuals, knowing that they have risk. And I don't use it to say, don't use a statin. I use it to intensify treatment, right?
Right.
Or to decide whether or not we need to intensify treatment. So I think we need to get away from this idea that you start screening by the age of 40. And by the way, the most recent USPTSF screening guidelines basically said, don't worry until you have to worry. So, don't worry until they're already over the cliff and then assess whether or not they're going to hit the ground. It waits too late. We have to come back to primordial prevention and identifying groups that should have therapy sooner, and that includes lifestyle. I mean, people will say, well, both of you are talking about pharmacologic therapies. No, we're not. We're talking about a discussion of making sure that lifestyle is first and foremost for everyone, regardless of risk, because it's just good for quality of life. But then for those individuals that are at higher risk, and you've assessed them, so that's the idea here is
Right.
don't forget to assess people. Then yeah, we should target our resources to those individuals, and that will reduce heart attack, strokes, and limb events down the road. So,
Right.
my primary care folks, I would say, don't be afraid to use things like coronary calcium. If you're not quite sure the context or the nuance, ask one of us, and we're more than happy to collaborate with you and design a care process that makes sense for you. And then you don't have to keep thinking it over and over, but your MAs can help identify these individuals. Your medical staff can help to make that a process that makes sense and is not just a money generator where everyone gets 1 to 2 millisieverts of x-rays just because we want to scan them. No, we have to make it make sense. But yeah, I think from one standpoint, we're using a lot of risk factors, which we still should, but there are the folks that will have an MI that don't have the standard modifiable risk factors, what we call SMRF, right? Standard modifiable risk factors. There are a bunch of SMRF-less people who have events, at least 1 in 4. So coronary calcium gets the disease, and it gets the disease severity or disease presence or absence. And that's very helpful, I think, and can be utilized beyond cardiology. It can be used in the primary
Right.
care setting. That's one of the things we're studying, actually. We have a CoreCal study. It's called the CoreCal study. And if you're interested, corecalstudy.com, and you'll see my happy little face in a video. But this is, we're trying to understand whether an ASCVD risk score or coronary calcium will help us identify people who are at risk. It's an interesting study. We're halfway through a 9,000 enrollment. And I'll tell you, as the one that's ordering these and sending out recommendations, I've seen a lot of calcium. And I've seen a lot of calcium zeros in people who we would have placed on a statin just because that we aren't. And so we'll see what the outcomes are. as we move forward.
Do you routinely look at your patients that you deem high risk ASCVD? Just as we're talking about coronary calcium, I think this is going to be a topic in a future podcast.
Yes.
Because true cardiovascular medicine is paying attention to polyvascular disease.
Yes.
And we know that if patients have one vascular bed affected, the chance of them having a different vascular bed is significantly higher, somewhere on the par of maybe 40%.
Yeah.
I tell my patients all the time when they kind of look at me a little bit funny and they say, well, how is this related to my foot?
Yeah.
And I just say plaque doesn't discriminate.
Right.
It doesn't discriminate where it wants to go. Are you routinely advocating for those patients you're finding coronary calcium in to make sure that they have screening ABI and carotid duplex, if appropriate?
Oh, you've hit my Achilles heel here, which is that our colleague Bob Ross, not the painter, has really leveled me up over the past 2 years, making me aware that peripheral vascular disease, and we're talking peripheral arterial, not veins necessarily here, but peripheral arterial disease is a big part of what we should be doing. So no, I hadn't been, and still have to find a care process where it's, again, you're asking me as someone that's talked about risk, about finding things, and I should be kind of, creme de la creme and thinking about these things. That's my Achilles heel. I'm still trying to figure out a way to make sure it's on my list of things to order and screen for when I have people with coronary calcium or evidence of any
atherosclerosis. Yeah.
It's tough.
I agree with you. It's something. It's underutilized. It's not just you. It's thankfully where I'm at. This is my daily life, and it's very easy to have a conversation with a post-MI patient, post-stent patient, post-PCI patient, and just say, look, because quite a few of them, you ask them about claudication, they have it.
Yeah.
In some fat, or leg fatigue, they have it, or you're going to find a diminished pulse. The carotid to me is the kind of the hard, not sell for the patient, but sell for even the provider, because, so many folks, if you ask a patient, you say, well, have you ever had your carotids checked? They say, oh yeah, they listen. My family doctor listens to them. And you're thinking, oh my God, that's great. And that's wonderful. But, let me show you a bunch of folks that had critical stenosis with no bruit.
Yes.
So I think that's something, obviously it's intertwined in ASCVD, it's intertwined in lipid management, because those patients, and that's why I've pushed the industry, that the PCSK9 folks, and now Novartis with inclisiran is saying, this is an arena you need to pay attention to.
Yeah.
Stop focusing on the AMI patient, because the cerebrovascular patient and the PAD patient needs your help too.
Yeah. Yeah, absolutely.
And secondary prevention for MI in that instance, if they've already had critical limb, or they've already had TIA or CVA, or they've had their carotid endarterectomy or stent placement. Shifting gears just a little bit, I know I'm trying to, you got to go back to work, as do I, as much as I'd love to stay here all day. Let's talk about new therapies. I mean, PCSK9 is not the new kid on the block anymore.
Right.
It should be a tool in every cardiologist and cardiology APP's toolkit, period, end of discussion.
Yeah. Exactly.
But it's not. I mean, I still am finding patients all the time, as I'm sure are you, that are post-MI, or they're high risk or what have you, and they're on Pravachol and Lovastatin and Simvastatin, and those are the instances, I just want to go outside and scream. And,
I
you
almost
know,
wish those meds were gone.
yeah, I tell folks the only time I use Pravachol is when they have HIV.
Yeah.
I mean, really, that's the only use I have for it, is if a patient has HIV, just because of the drug-drug interactions with the other statins. But
Yeah.
a lot of those patients, you know, end up on PCSK9 just because of their high risk. PCSK9, you know, any kind of brief thoughts about that? I mean, you're more of an expert with it than I am, for certain. It's really, do you see any opportunity, or where we should be focusing? You know, we talked about the AMI patient, which is the poster child, but you know, we need to be looking beyond that. Obviously, FH,
Yeah.
in those individuals. But
Yeah.
any
No,
opportunities?
no, it absolutely great question. So, you know, our site was one of the Fourier sites for evolocumab, or now Repatha. And the absolutely, it should be part of the armamentarium. So this is, you know, for those that are kind of trying to figure out the lipid space. But this goes for any type of therapeutics. First, you go with guideline, because they've thought about this. There's been groups of people and they look through randomized clinical trials. So when you go through guidelines, you go through evidence, and what they specifically point to is outcome evidence, not just lowering a surrogate. We'll keep calling LDL cholesterol a surrogate because there are folks that have other reasons for having atherosclerosis, but certainly you need LDL cholesterol. You just need cholesterol, ApoB particle cholesterol that are atherogenic. But you know, PCSK9 inhibitors, the problem that we ran into, and they kind of did it to themselves, that cost, right? The initial kind of out the door cost, 14,000, wasn't helpful. After being shamed, I will point you out, my pharmaceutical partners, after being shamed, you know, they dropped it in half, but still 6,000 to 7,000 is a lot to swallow. You and I both know that for people who have commercial insurance, there are definitely coupons and ways for commercial insurances to be able to absorb some of that cost, but the Medicare, Medicaid patients don't. So they fall into these donut holes, and when you're on fixed incomes, that's very difficult. So we do have to figure out costs. That's a point where I would say, again, to my pharmaceutical partners that are coming back at me and saying, well, there's only, you know, 10% or less of folks using PCSK9s. You did that, you know, you did that to us. And so did the insurers. So, you know, there are many people, the blame can go everywhere, including us as clinicians, not paying attention to adding, first of all, putting on a high intensity statin, adding ezetimibe, and then coming out to PCSK9. So there are things that we all have a stake here. Should we be using it in primary care? Absolutely. Not just family, you know, familial hypercholesterolemia, but certainly those individuals, it's very, very difficult to get LDL cholesterols to less than 70 on just high intensity statin therapy and ezetimibe alone. Of course, if we're thinking guidelines, the guidelines just say less than 100, right? For anyone greater than 190. Right. They're saying less than 100, but you and I, we do a little bit more nuanced evaluation on these individuals, and that's why I say coronary calcium can help mitigate my intensity of lipid lowering therapies if it's zero. But in any case, when we think of, you know, should that diabetic individual be considered for PCSK9? Yeah, they should. Of course, you know, the guidelines have said moderate intensity, use ASCVD to go up to high intensity, not to rule them out of therapies. And again, ezetimibe, great. You know, it's a wonderful addition, but PCSK9 inhibitors, I'm always thinking of the FACC AMI study and more of these observational data studies that have said lower is better. And I cringe when I get partners that are successful at getting on high intensity ezetimibe and PCSK9, and then I get a call and I'm like, oh man, they got their LDL down to 20. Should I just back off? And I'm like, what are you doing? Why would you think that?
Because heresy.
You know, I'm first of all, First of all, physiologically, LDL cholesterol is 30 or less. We just in our societies we've let it and be normalized that it's okay to go
And it's
30. And
level of 10 in utero.
yes, yeah, exactly, exactly.
10 in
That's
utero for
development.
normal neurodevelopment.
Yep.
Yeah.
And so there's no reason for us to be above 30. There really isn't, other than our diets and us letting it do that. Um, the other part of that is if you want to look at long-term safety, I always point them to the Fourier trial. They did well. Odyssey kind of screwed this up. Praluent, alirocumab, you guys messed this up. You gave the people the impression that once you get to less than 30, you could back off and somehow down titrate. That's where that comes in, by the way. People always point that out, and I say, well, Fourier did not. And we have cognitive studies in Ebbinghaus, et cetera. They're still being followed. There are nearly 500 individuals that were able to achieve LDL cholesterols less than 20, and they're still being followed. So, from a safety standpoint, no worries there. But I do think that, again, when we think of PCSK9s, think of them as interfering, and that now we have monoclonals and we have small interfering RNA. But coming back to evidence, so guideline and then evidence of outcome reduction. What we do have is we have Improve It. We have all the statin trials. So Improve It for Azedia. We have Fourier. We have Odyssey for the PCSK9s for MACE reduction. We'll hear about Clear, hopefully at the end of this year or beginning of next year, for bempedoic acid, right? So Nexletol or Nexlizet when you combine with Azedia, ezetimibe. But I don't reach to them first because the outcome trials, I want to make sure that just lowering LDL cholesterol is not the only thing I'm doing, but that I truly want to be reflective of a reduction in MACE. When we think
Are you writing inclisiran right now?
I am. I am. And that's because of again, the signal that we got from Orion 9, 10, and 11. I am an investigator in Orion 4. So I have a conflict of interest when I talk about those things. I'm not being paid directly. It's to my department. But I am prescribing inclisiran, and I'll tell you why. Medicare, Medicaid. When we talk about PCSK9 inhibitors or interfering medications, they fall into this donut hole. When we talk about inclisiran, because of its FDA approval, it's an injection that has to be done by a clinician. So it falls under Part B instead of Part D. So I don't have to do prior authorization. And in fact, cost-wise, it costs less to the patient. These 2 injections, 3 the first year, than a PCSK9 inhibitor or monoclonal antibody, I should say. So yes, I am, but because I do.
You see more of an ease of use.
Ease of use, it matches well with the care process, and there's less of an adherence issue with regards to inclisiran versus 26 injections, with a PCSK9, or 12 if you're doing the monthly. But still, they have to refrigerate it. They have to remember to pull it out. And by the way, it feels better if you leave it out a day before you inject with this pen. But inclisiran is one of those that I think, while the MACE outcomes are not yet out, it pushes on that same protein just earlier in that cascade, right? So at the RNA level.
Yeah, I haven't. I mean, in full disclosure, I've written one inclisiran for a patient that has that same issue,
Yeah.
donut hole issue. My drawback with it is number one, they're not going to have outcomes till 2026.
No, that's right. That's right.
Yeah.
We're still
So
enrolling.
I mean that's a huge, and that's what I told when my pharmaceutical colleagues came and they said, well, why can't you write, or why won't you write this? What's your drawback?
Yeah.
And I said, well, think about if I'm seeing your mom. And she says, well, what is this going to do for me? Well, it's going to lower your LDL-C.
Yep.
Okay, well, is it going to protect me from heart attack or stroke?
We don't know.
I don't know.
Yep. We don't know.
We're working on inference here.
Yep.
So that's a big drawback. I think Novartis kind of got a little too excited. It's just my personal opinion.
Well, they have the same problem cost-wise. They have the
Right.
same
Well,
problem.
exactly. But it's, and this from the 4A trial is like, if you looked at Repatha,
Mhm.
their data, even though it was like a secondary analysis with PAD,
Yeah.
it's very compelling. Very
Absolutely.
compelling.
Yes. Yes. The
So, I
paper
mean,
by the knockout.
I
Yep.
feel like any of these, these newer agents that are coming out, and I love it because, I'm not saying this is going to be a bad drug, or inclisiran is going to be a bad drug or anything like that.
Yeah.
It has big shoes to fill in terms of, are you showing reduction in all those vascular beds? Don't just show me MACE events. Show
Right.
me everything.
Yes.
So we'll see.
Yeah.
But
Yeah. And I would argue we should be having a MACE male, right? Major adverse limb event outcome as well as part of all these trials.
Sure, sure. I mean, the mortality and morbidity with male events is just so staggering, and
Yes.
I'm not going to steal Bob Ross's thunder at all, because
It's okay.
he is yeah, I mean, he and I have already started planning for next month for PAD Awareness Month, and it's yeah, I'm not going to steal his thunder. But
Okay,
it
we've
is
teased it.
encouraging to see inclisiran and Nexletol, all these things coming. That lipids, lipids are not sexy. They're not sexy like stents or ablations or something, but you can make a big difference, and you can do a lot for the patient, for their family, over the course of their life. So it's exciting that people, that pharma's paying attention to it. They're not saying, oh well, let's come out with the next best antiplatelet or anticoagulant or whatnot. How can we further what we know about lipids? And I have no doubt that inclisiran's probably going to have work in the manner in which we expect it to. It's
Right.
just, I think a lot of folks, if they're kind of on the fence about that, yes, if access is a problem, if adherence is a problem, if donut hole's a problem, yeah, sure.
Yeah.
But I do have a real discussion with my patients that I've done one for inclisiran. I just say, look, this will lower your LDL. I don't know if this is going to reduce. What I do know about lowering LDL is it does reduce your risk. So there's inference being made here, but this has not been studied in this arena.
Yeah, no, I love that. I mean, that's a true shared decision-making
Yeah.
conversation. And cost
But I
has
think
to be
folks
part of
need
it.
to realize that, because, folks, how it is. Folks come in with a flyer. They say, here, this is brand new. Write it. It's new. It's fancy. It's a nice, shiny toy.
Yes.
Look at the data. Well, the data's not there right this second.
No,
So,
and you'll see that reflected, as much as we probably don't like our P&T. I love my P&T committees for Select Health and for Intermountain. They're reasonable. And when I went to bat to have the ability to prescribe Leqvio or inclisiran at Intermountain, they pushed back on the outcomes, and I said I absolutely agree. If you want to say, well, fail a PCSK9 inhibitor and then go to an inclisiran, fine. Very few people will fail a PCSK9 inhibitor. Outside of any idiosyncratic, specific to the patient type of symptoms, and or just, injection reactions where they're like, I have one patient who fears that next injection because it's 26 of them. And they feel like they could tolerate 2 a year. Rather than 26. And so for me, that's failure, because it's enough of an anxiety that they will not take their PCSK9 inhibitor. The other part is again, and that's why I started with guideline evidence. As we come back to, imputing LDL cholesterol lowering with, improved outcomes, I think that's enough, and we're close enough with that data that rises up. So for me, with patients who I'm trying to decide PCSK9 versus Leqvio, PCSK9 always wins out on the outcomes, on the safety profile. Not that Leqvio is any less safe, by the way, but just because we have years of data in the general sphere now, in the general population. But when it comes to cost, if they can't access PCSK9, then I feel like inclisiran is a perfect, great alternative. Again, leaning on that same
Right.
protein. I don't have the outcome data, but I'd rather have them lower that LDL cholesterol than not at all.
Correct.
So
Correct.
that's exactly where I fall in this. I don't reach for it first, but certainly when it comes to access and being able to
Absolutely. I
get
don't
them.
want my patient unprotected. That's for
Yep.
sure.
Yeah. Yep.
Um, well, Viet, I thank you for being the first. Um, this has been fun. I know I said initially, hey, we're going to do 30 minutes. I think I laughed to myself, as you probably did. It's like we've never had a phone call or discussion that's been 30 minutes for
That's
us.
right.
So it's never, that was wishful thinking at its best. But you know, our hope with these podcasts is to be able to give some folks just some real world discussion and talk very candidly about guidelines and what we see and what we feel and how we approach things and opportunities for success, but also some opportunities for improvement as well. And I think this is just the tip of the iceberg. So I thank you for carving out some time this morning to be a part of it.
Oh, thank you. I look forward to our future podcast from you, and certainly I think we've covered many topics that folks will be interested in having us retread or tread more in depth later on down the road. So I look forward to where you lead us, Brian.
Well, I'm not sure where we're going, but we're going somewhere. Well, thank
Just
you.
not off
Thank
the
you.
cliff.
Exactly. I will put the fence up. We're not going off the cliff. Well, you have a good day. For the folks that are going to, you know, that are watching, there will be, the month of September is PAD Awareness Month. I will be talking with Bob Ross, not the painter, unfortunately. That would be an interesting feat. But Bob Ross, who is has become a kindred spirit of mine in terms of how passionate he is about peripheral arterial disease. So look for that. We're going to have great discussion on not only pathophysiology but routine testing, and actually talking about some critical limb ischemia cases and how limb salvage really is a team sport. So stay tuned.
Thank you.
If there are any questions regarding the podcast, feel free to email myself or Viet, and we'll be happy to help as it pertains to lipids. All right. Have a good day, Viet.
All right. See you,
All right.
Brian.
Take care. Bye-bye.
Bye.